this is an initiative of the University of the Philippines Medical Alumni Society. So we are going to have our webinar for this afternoon. Okay. So this is the UP Med webinar series that's regularly done. Okay. So it delves on important, current, and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine specialists, and other workers. So registration is free, so I encourage your colleagues to log into our webinar this afternoon. Okay. So we are now in room 218 of the emergency room complex of the UP-PGH Taft Avenue, Ermita, Manila. It is about 12:05 in the afternoon. Okay, so welcome participants. Today's topic is, Doc, gawin mo ang lahat. A discussion on medical futility. So the objectives of this webinar are to learn and understand the various definitions of medical futility, discuss and process and evaluate and responding to our request to a potentially inappropriate and inadvisable treatment, and to understand your obligations at the end of life care, and to learn the hallmarks of high-quality end-of-life care. Okay. Our speaker for today is Dr. Aurelio Muyot. Dr. Muyot is a graduate of the UP College of Medicine, and he did his residency in internal medicine at the University of Illinois, Chicago, and continued on in the same institution for his geriatric fellowship training. He completed his geriatric fellowship training at the University of Tennessee, Memphis. In 2012, he became the medical director of Infinity Hospice Care, Las Vegas, and Nevada Palliative Care. Currently, he is an assistant professor in the Department of Primary Care, College of Osteopathic Medicine, Toro University in Nevada, and serves as the program director of the Hospice and Palliative Medicine Fellowship Training Program of Opti West Nathan Adelson Hospice in the same state in USA. He is a preceptor for the geriatrics rotation of internal medicine and family medicine residents, as an adjunct clinical assistant professor in the Department of Internal Medicine of the University of Nevada, School of Medicine in Las Vegas. Okay. Without further ado, may we now call on Dr. Muyot to give his talk. Please, a round of applause.
So, maraming salamat po. Kahit matagal na po ako sa SACE, nagtatagalog pa rin po ako. So, magpasensya na lang po yung accent ko kasi kung minsan pinupunakan ng mga estudyante ko. So, just to get an idea, I talked to some of you guys. So, you have 3 residents, and I guess nakabukod kayo mga residente dyan na wala yung mga ako. Nakilala ko ng mga attending. So, in our training, we're all trained, we're sort of in various stages of our training. So I'll probably follow you guys to get your opinion. I want this to be a two-way discussion. This is not me just lecturing and telling you what to do, because this is something that you will be encountering and doing as you progress into your training and then go into clinical practice. So if you ever go to Las Vegas, this is where I teach this. This is actually at the North Warehouse. It looks nice, pero shop. So just to remind, di po ba yan? Wala po kayo dito. We have a shop for our students, but it's for college attire and equipment. So just to reiterate, our objectives for today are fourfold. First of all, I'd like to learn and understand the terms and definitions used when we discuss medical futility. So we'll set out first by defining the terms that are being used when we discuss medical futility. And then once we've gone through that, then we'll go through the process of evaluating responding for requests for potentially inappropriate or inadvisable treatment. And I'll teach you how to go about the process. Again, this is something hopefully that you'll be able to take home and be able to use in your practice as you go on. Third, even when patients decide that they're not going to go for aggressive treatments, I want you to be able to understand that there are obligations when it comes to end-of-life treatment. Very important that you stay involved in the care of your patients. And last, we'll just kind of go through some of the hallmarks of high-quality end-of-life care. So whenever I talk to the students or residents, I give them a case scenario. I think a case-based learning format is something that works really well. So you're in the ward, this is a submitted to your hospital. She's got non-resectable lung cancer, she's submitted short script. She's a diabetic, she has hypertension, and she has chronic kidney disease. Now she's a widow, or next of kin is the family, so daughter's next by bedside. And when she was admitted, her chest X-ray showed bilateral lung masses right below infiltrate. So, question for the pre-residents: what stage is her lung cancer? Why? Bilateral. So bilateral lung cancer is staging AJCC, stage 4. All right. Even though it's still confined to the lung. So she's got this infiltrate. So she was diagnosed with pneumonia and started on antibiotics, oxygen fluids. And then you keep on seeing her every day. On the third day, now you know that she seems to be getting worse. She's in respiratory distress. The respiratory rate is up, pulse rate is 108, blood pressure is starting to go down, and her temperature is 98. So what do you think is going on with her? Clinical diagnosis, what's the problem? Septic. So septic, you got her systemic inflammatory response, plus you got a documented infection. And now she's getting hypotensive, so you're actually anticipating that she's probably going to end up going to septic shock. So she's hypoxic. You have her on non-invasive positive pressure ventilation. She now responds only to vigorous stimuli and quickly goes back to sleep-like state. And when you get her labs back, her white count is way down. She's got her chemotherapy, and she's in renal failure. So she's got multi-organ dysfunction, MODS. She does not have a living will. So, as a good clinician, or as the good clinician that you are, go ahead and talk to the daughter and basically give her the information, what your thoughts are. And then after forming the family with condition daughter request, don't do not how would you react to that? Spend a lot of time, you've seen this patient with your. So let's go through the process here. What do you think are some of the treatments that potentially you'll be ending up discussing with the daughter? Intubation, mechanical ventilation, what else? Dialysis for blood pressure and support. What else? Cardiopulmonary resuscitation. So we got all these three, and you've identified that. This is probably what's going to happen to your patient if you go and decide to do that. How do you think, just from your clinical experience, how do you think she will do with multi-organ dysfunction and advanced cancer? What's her overall prognosis? All right. So keep that in mind. So let's first define. When we say something is futile, futile means it doesn't serve any purpose or it's ineffective. And futility basically means you have to have a goal. Is that goal achievable at all with whatever I try to do? And there's an action that I can do. For example, I can support the blood pressure by starting blood pressors. I can support the kidneys by patient on dialysis. I can support the patient's respiratory system by intubating with mechanical ventilation. So you got a physiologic goal there. Let's define that a little bit further. So for medical futility, we come to that definition when we have something, perhaps a goal that we have in mind, and there's an action or actively aimed at achieving this goal. However, we're kind of thinking it's probably not going to work. Maybe temporarily, but in the long run, it's probably not going to work. So why is it so controversial? Medical futility as a concept is nice, it's defined, but you ask 10 different doctors what is futile for a patient to get different opinions. I'll give you an example. I was talking to a family one time about a patient who had a heart attack, already had cardiac dysfunction, respiratory failure, kidneys were going down. So the family flew in from another place and then we discussed about prognosis. So they understood it. The nephrologist comes back later and says, no, the kidney numbers look good. Just look at the numbers. Maybe the creatinine got a little bit better. But what do you think? Is the patient really going to do very well in the long term? The answer is no. So even if you have other consultants, and this becomes an issue, as you go into your practice, you have different consultants coming in. Make sure you communicate with another consultant, especially when it comes to a situation when things become very critical. So different people have different standards. It's basically based on what the standards are for the community. But what are those standards? Again, that's a moving target, so it's not as well defined. If we start that discussion on futility, some patients will think that's basically a unilateral decision by the physician, and it's a conversation stopper about the patient's condition and prognosis. If you ever encountered with me na encounter na kayo ng pamilya na ayaw natin pag-usapan yan, kasi parang bad news yan, ay narinig yan, lagi kang lumala sa question. So this is something you may encounter. You have to sort of be able to confront that situation and expound on that. We are all humans. We have our own values. If we start a treatment, ethically, is there any difference from the growing treatment? Let's say you start at small accident and mechanical ventilation. Is there any ethical difference when you stop ventilation versus not stopping the first time? Yes, no, maybe. So inisip na rin tayo. Actually, that was an issue. Kasi I worked with an ethicist sa hospital. And she's about this now, I see her church, Catholic church. Not only church sa United States. They've already come up with a position that it's not any different stopping treatment versus actually initiating treatment. So from a church standpoint, I'm not sure about the church, so that's something you may want to look into if you have. And we all have our values. Some people will not want to confront mortality, not want to be someone to bring up that subject. So there are been situations in the hospital where some doctors actually had to be removed from the case because they were not willing to make that transition for someone who doesn't take care of still feeding them different information with the hope that this patient's in there actually prognosis is not very good. And then it's something, when you hear bad news, how many words you really hear out of that conversation? Probably the first few words. So if you try to do your explanation, make sure you kind of keep it in small segments. Kasi pag narinig na nila ay hindi yata maganda. Whatever you explain later on, hindi ka na marinig yan connection of the pamilya na close. So just be careful. So what qualifies as medical futility? We can look at it from a quantitative standpoint. So if I were to give you a percentage, now you guys are there? Mr. Jack dito? Yes. So Mr. Jack dito, raise your hand. Okay, Maria. Alright. Kung out of 100 sa tingin nyo, ano yung chance na we would consider? Ano yung cut-off nyo ng futile? Ilang percent? Give me a number. Quick. 40. 40. Reassess sa tingin nyo. 5%. Stepe lang. 5 din kayo. Ibigay sa mga training nyo. Okay, attendance, 9%. So out of 100, and then chance of success, what would you consider to be high? So 5, 10. So actually, if you look at the literature, there's a couple of definitions. The most stringent one is less than 1% chance out of 100 to achieve that specific goal. Some would say anything there about 2 to 5%. So mga estudyante, kasi sa akin 40%, medyo mataas pa yun. Actually, that's a pretty good chance. Pero estudyante pa kayo, okay lang yan. Estudyante pa lang. Alright, so physiologically, we count the computation. What's my goal? I'm going to put them on a ventilator because physiologically, perhaps I can help the respiratory muscles work less hard, increasing oxygenation. If you have natin physiological, qualitative is something I want you to think about. So if you put something in place, will this treatment actually provide a benefit that can be perceived or appreciated by the patient? Kung minsan kasi ang pamilya, ang na naghahanap ng goal na yun. Ay, medyo nag-link lang na konti. Neurologically, nag-improve na ba yan? Hindi pa rin, comatose. So they hang on to certain things. So be very careful when you talk to the patient's families. Especially kung maraming consultants ang dumarating. Kasi nga, kung iba-iba ang signal nyo, ano na nga medyo yung situation very emotional na sila. Tapos kung ano pa narinig, lalo pa silang nalilito nito. So very important that you communicate with your consultants or other subspecialists and specialists involved para at least they have a good view, a clear view, and a true view of what's going on. So, put it a little bit more academic. This is the recommendation of Society of Critical Care Medicine. So this is what they list, 4 items they would list as potentially inappropriate or inadvisable. We already talked about physiologic effects, so no beneficial effect. Everybody would agree it's futile. The second consideration is the treatment going to be beneficial or not. If it's unlikely, and again the percentages are a little bit different depending on who you ask, that's also considered perhaps an inappropriate treatment. Treatments that are of uncertain or controversial benefit, because as physicians we can do things off-label, even though you can want the approved for that, sometimes they use this stuff and you can use it for. Number 4, especially in this country, treatments that are beneficial but are costly. Cost is a big consideration, especially for people with limited coverage for health insurance. Lalo tayo dito sa PGH, nalala ko, kami nagbibigay ng pera ko minsan para makabili ng supply ng mga pasyente. Even sa private practice, some of them will have limited resources, and plus maybe a consideration when it comes to deciding whether to initiate a certain amount, a certain treatment, or how long do we try this treatment. So, again, from an academic standpoint, this is actually a study from 2013 in 5 ICU patients. So they surveyed a number of physicians working in the ICU, both surgeons and internists. So the main consensus when they asked as far as what is considered futile is, what are the burdens? Do they outweigh the benefits of the treatment? So 58% said, yeah, I would consider that futile. Or number 2, and again, you can have several reasons, treatments will not achieve the patient's goals. Number 3, this is an ICU population, death was imminent. So regardless of what they did, if you may slow down, delay things, but death was still imminent in a number of those patients. And then number 4, the other reason they gave was the patient will not be able to survive outside the ICU. So just your fellow physicians, just hearing them out, these are some of the reasons that they would probably talk to families and consider certain treatments as potentially inappropriate. So remember your code of ethics from the PFA. I just got this online. So what are your responsibilities? You should exercise good faith and honesty when you express opinions of diagnosis, prognosis, and treatment of a case under your care. So being straightforward, I know there's a lot of uncertainty sometimes, and some people do recover, but just give them a straightforward answer. Again, just try to make it something understandable. If you're talking to someone, depending on their level of education, you have to also tailor your discussion depending on the meeting you have. Timely notice of the worsening disease should be given to the patient or the family. It's very important because the more patients are involved, the chances are when you have that difficult discussion at the end about what to do on someone who appears to be terminally ill, it comes out a little bit easier. Is it always going to be okay? No. Sometimes magagalit pa rin ang mga pag-ila sa inyo. Dok, bakit naman napaka-negative niyo? Ganito po mga rason natin. They may believe you, they may not. But again, just maintain your professionalism. And I've been in certain conditions na naginigaw ng mga pamilya and they would just walk out of it. So if you go back to the oath of Hippocrates, maliit lang to, but it says here, I'll just read off this. The one that's in the red rectangle basically says, I will follow that system of regimen which according to my ability and judgment I consider for the benefit of my patients and abstain from whatever is deleterious and mischievous. So it's very important that your care should be still directed to the patient. You have to deal with the families, of course you have to deal with the families. But I think your families can be also a useful ally when you start, as long as you keep them informed along the process on what's going on, so that when that difficult discussion happens towards the end, hopefully it won't be something that would blow up. All right. So what niyo po itong gagawin? Huwag niyo po papadala yung nurse at sabi, the doctor will see you now, but I can't promise that he'll talk to you, but he'll see you. Importante na kausapin natin because actually this happened in real life. I was in a family meeting that did not go very well. I was doing palliative care. The attending physician already had a bad relationship with the family. He did not go into the room during that discussion. So that discussion without that particular doctor in that particular room actually did not go very well because they were looking for him and they were actually ready to kind of get on his case. So we had to have another meeting later on when things kind of calm down. So when you identify this concept program, how do you approach? The first thing that you have to sort out is, pag sinabi na gawin natin, what does that exactly mean? So there are 4 scenarios that will help you understand. Is it everything with a reasonable chance of prolonging life, but not if suffering increases? Again, you still have to consider emergency treatment. Second, so I'm going to do something that has a reasonable chance of prolonging life, but we're not going to care if the patient suffers in the process. Number 3, everything that could potentially prolong life, regardless of any effect on the suffering. So second and third are kind of similar, but then the other option is everything that might relieve suffering but may shorten life. This may be something that also may be an option. So the first thing you need to do is clarify what's driving that request, because a lot of times it's the fear of the unknown or some of their emotions, or families that have had unresolved issues between the patient and the family's trying to hang on and sort of use that as leverage. There's also that fear of abandonment. So it's very important when it comes to that point that the end of life is being discussed, be available. You don't want 24/7, but make time if they request to see you and discuss what's going on. Conditions and prognosis. A lot of times, the explanation might help. And also, if you need to implement treatments, perhaps will not work. You will often hear, well, sige, ito na ganyan, bumalik, or sa TV nakita ko, nag-recover pasyente. Hindi po yan tunay na buhay. Hindi po yan nanay or tatay. Ang nanay po at tatay, ito po ang pinagdadaan nila. Ito po yun sa nangyayari sa nakikita nyo sa TV o yung kinsan di mga sa mango. So, always individualize yung discussion. Keep it local. Spiritualism, vitalism, and faith. Belief in life and faith also will drive that. And as I mentioned, sometimes it's family dynamics. Walang kinalaman sa health, but it's the unresolved family dynamics that may sometimes drive that discussion. So, once you've understood what's right behind that, the next step is try to think, what are options or what's our goal? So once you've understood that, then you can sort of set your goals based on if the patient was already able to do that beforehand, or sometimes substitute the judgment and family. To their best of their knowledge, how would your mom or your dad do in this situation? Is it prolonging life? Is it relieving suffering? Can we mix a little bit of the two, or what's the more important goal? And then once you've understood what's driving it, what your overall philosophy is, then you start coming up with treatment recommendations. So, as you already identified, intubation, mechanical ventilation, that's a discussion we're probably going to have.
dialysis, CPR. Now, when you start talking about be ready, because sometimes, as I said, the discussion may not go very well, that they may be mad at you, or they may displace some of that anger towards you when you have that discussion. Bakit naman ganyan, Dok? Napaka-ano naman, napaka-bigat naman yan. O bakit mo sinasabi niya, hindi ko mangyayari yan. So just calm down, wag na wag ko kayo nakikipag-away yung kasi if you already have a situation that emotionally, it's already heightened. Once you start raising your voice or engage in a shouting match, guess what's going to happen? Magbabawa ka siguro or not. It's not going to turn out very well. So, make sure you acknowledge or legitimize some of their responses in terms of their emotions. And then sometimes they will let you know, oh, it's mahirap nga pala. So tell me more about that. And then empathy, it's very important. So I'll pick on the residents. Empathy versus sympathy. Anong diferensya nila? Like volunteer, who wants to go on? Yes. Yes. How about that?
Empathy means it is to put yourself in the shoes of the patient. But sympathy, it is to naawa sa kanya.
Empathy is actually share and understand that experience. And it's sometimes hard to do that be like unfortunately, I have to go through the same experience with my parents and that discussion. So I use that experience but it's never ever going to be the same as what your patients and families are going to do. But at least you understand what you're talking about. Sympathy is just expressing sorrow or care. So that's sympathy. So you want to convey that you actually are with them, trying to share that experience, to understand what's going on during that time. And this will make for a more effective exchange. With you, the patient's able to make a decision. First experiences, emotions, and we already talked about safety. So we will also go through emotions. There are times when you go through these family discussions, especially with very hard decisions, that you will feel emotionally drained, you may get emotionally involved. And that is something, as professionals, we're taught to suppress, but it's something also that you have to sort of learn that it is something as humans that it's also an experience you will go through. So when you have those discussions, it's not only the family, it's not only the patient itself, but you yourself will go through an emotional experience. So you've done your part, you figured out what you want, figured out philosophy and recommended treatments. However, there's still some differences. So start on think about perhaps is there a common ground that we can agree on. So if not, I know Eva, you're an ethics consultant here.
I'm not ethical.
Yes, you are. But we do have the pressure in TJs to have ethicists.
Oh, well, we have ethics. Yes, governments.
Okay.
But most of the time, also like for pediatrics, for our department, they call the priest. So here says that there is an ethics committee within the Department of Medicine. Oh, in the hospital. Okay. But for pediatrics, we also very much a part of our practice is calling the priest, especially for the very young babies and life care. For spiritual support.
I'm just curious because you have a palliative care fellowship here. And are they involved? Are they involved in discussions about those in care?
They're usually co-management.
Yes, this is I did palliative care consultations. This is what I did about 0.8% of consultation was about discussions about what the options are. And a lot of times you get the idea that they just want to be heard. Sometimes you're busy, and it does happen in our profession as physicians. We go one patient to the other, one hospital to the other. Sometimes I just need someone to sit down and explain what's going on. So hopefully you'll develop that approach during your training, and then carry it on as you go into your private practice. Some may say, well, I want to try mechanical ventilations and all that shot. But after a while, if things get worse, maybe time to have another sit down. So the goals are not static. These are goals that can change over time. And then I'm not sure hospital-wise here if you have any policies on medical futility. It's probably not. So, all right. So, our hospital system, actually part of the ethics committee there, we do have a hospital policy how to deal with those difficult end-of-life decisions. So, you had a discussion, negotiation and treatment, but they're still insisting on perhaps some treatments that perhaps may not be as beneficial. Again, acknowledge the patient's family's treatment philosophy, because providing respect to the patient and the family is very important, and will help that relationship. If there are any other situations that perhaps they would question whether these invasive treatments, let's say, no, there's a ventilator, I'm not sure now it was work, but that is your opening to start having that discussion. And we should start rethinking it. Ano ba talaga ang punatulog niya, or what's our goal? Very important, because the sicker the patient are, the sicker the patients are, the most likely have a multitude of consultants or attendings, and they come in quickly, but sometimes they may give information related more towards what they're looking after. But again, as the attending physician, you do have the overall picture and control of how things will go. And then always, as physicians, use your clinical judgment on treatments that are advancing the patient goals. So this is, I just included this because I actually gave this talk last year as part of our ethics requirement. So from the other side of the ocean, these are our opinions as far as futile care. So from the American Medical Association, their opinion, and this is the number, physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting that patient. And then second, when this is sort of a follow-up at the end of life, when further intervention to prolong the life of a patient becomes futile, physicians have an obligation to shift the intent of care towards comfort and closure. So when you start talking about maybe perhaps looking into maybe withdrawing or stopping treatments, what I would recommend is look into the options. So if we're going to do that, what's our next step as far as treatment? Because treatment goals will change, but the families would like you to continue to provide treatment and not just abandon them as we make that shift from our intent towards comfort care at the end of life. So just to give you an example, the hospital I work with, they actually have a 2-page memo and a policy. That's the hospital system where I work at. And as I said, we have actually, during our ethics committee, we discuss difficult cases every quarter. Just to go about some of the discussions are interesting. May asawa na hindi na alam and then namamatay na darating yung asawa. Who's got the ability decision. So, or let's say sa mga kids and mga foster kids, ito mahihirap. That's why it's nice to have, and you have that committee to be able to help you through these difficult times. So, after additional meetings, the daughter now decides not to start dialysis, intubate, and resuscitate. So I'd like to just kind of introduce, I don't know if there are any palliative care fellows here, but palliative care is something you actually do at any stage of the disease. But your shift is more towards symptom care and management of someone as the disease progresses and becomes life-limiting. And then when she gets to that stage, you're at the end here. And so rectangles end where palliative care is your basically your approach. So when the patient's family decided to make that shift, again, you still have to keep in mind the same principles of ethics, the four things: autonomy, beneficence, is it going to be good? Non-maleficence, not to do harm. And last is justice. And you're still obligated. The obligation as a physician when it comes to that point is to offer treatments that are consistent with the professional standards of care and confer benefit and the goals of patients and the family. And we always be around to assist with those decisions and provide support and ongoing communication. So I'd like to end with this slide, which is basically when I help transition patients into end-of-life care. We're always available and make sure you provide that symptom control, whether it's pain, because even in non-cancer patients, your heart failure patients, your COPD patients, even some of your dementia patients, at the end of life will deal with pain. Other symptoms such as dyspnea, nausea, and vomiting, others, always be there and continue that commitment to the patient and family. And then last, if you can provide support, as Dr. Rapachak said, we got spiritual support. You can also help provide or arrange for services. So that's my thought for the afternoon. Do we have any questions, audience, or webinar?
Thank you, Dr. Muyot, for that very insightful lecture. And before we proceed, we just like to thank our legal partner. The require and the Filipino number platform. Okay. So before we go to the question and answer portion, we have for the leaders of the field of geriatric medicine in the Philippines. She's a professor in the UP College of Medicine and is currently the director of the Institute on Easy of the National Institute of Manila. She is also the immediate past president of the UP College of Geriatric Medicine. So
I think really this was a very excellent discussion, very well placed, and I think the residents and the students here and our social workers, nurses, so are very appreciative of the discussion. I remember when we were still medical trainees, me or also here in the US, there was this controversial one who was already brain dead vegetative for a very long time. And the doctors did not want her to continue to be on the ventilator. But the husband, I think, was against that. So ethically, I think the doctors did not feel that the ventilator, etc., and thinking true, in fact, was benefiting her at all. No, but legally, that was where the problem was. Because legally, they had to go with the decision maker, which was the husband. So, although we are ethically not bound to provide, to do, for example, treatment that we think is futile, we always have that legal question behind us. And I think that is what drives some of the management, for example, in certain situations. In the US, for example, where ICU care is paid for by Medicare, right? There is an enormous disincentive to stop treatment when somebody is paid for it anyway. And from what I read recently, about 20% of deaths that occur in the intensive care unit are actually futile, or cases that are futile. So I really appreciate that Dr. Muyot talked about benefit, because essentially, really, this is weighing benefit versus harm, or what will cause more suffering for the patient. And remember that for a treatment, for example, or management to be beneficial, it really has to be determined by the patient. It should be felt by the patient. That's why we don't just give treatment to increase the blood pressure. There has to be something beyond that, that the patient will really feel is beneficial to him or her. Sometimes when I go into a discussion of end of life, especially withholding or withdrawing life support, I tell the family and ask them about their faith. What does their faith tell them about end of life? And many of them, because this is a Catholic country, believe in life after death. And the value of suffering sometimes is very Catholic, somehow in nature, that somehow there is a redemptive purpose to suffering here on earth. Kasi siyang bisyo kasalanan, kaya maghihirap po siya ngayon. So parang hindi nila pinapansin yung paghihirap ng tao, na ganun ang nangyayari. But sometimes I ask the family, you have to understand, I personally believe that there are situations that are worse than death. If you believe in the afterlife, if you have faith, and etc., there are situations that are actually worse than death. And to me, that would probably be, being in a ventilator for a long time when you can no longer anyway interact or meaningfully enjoy your life. So yun yung mga sitwasyon that, and some of the conversations that I have been discussing also themselves. So there is a new way of that do not resuscitate order. Mahirap kasi interpret ang DNR. Diba, pag nasa ER na, nasa ICU emergency situations, even if you have a DNR, it's sometimes difficult to operationalize. So, Dr. Mark Abad and I work at the Jesuit Health and Wellness Center, and we are adapting the POLST, the Physician Orders for Life-Sustaining Treatment. And if you look at that, you can Google the POLST. There are POLSTs all over the US where it started. California, for example, it gives us specific orders. Yung DNR, hindi yung galing sa pasyente, kundi para siya naging order ng doktor. So, for example, if the patient is short of breath and please start antibiotic or maybe intubate, parang gano'n. So there are different situations in that form, and I think that is going to be a useful form to discuss and to have here in the Philippine General Hospital. Okay. So one other thing that needs to be discussed is when and when you start this kind of discussion. Pero sabi nga nila, Dr. Muyot, sa geriatrics, dapat hindi ka pa, medyo bata-bata ka, wala pa masyado nararamdaman. Sinasabi mo na dapat sa pamilya mo, ang mga kagustuhan mo, yung end-of-life choices, no? Of course, that's ideal, but most of the time, it happens when the crisis occurs. One thing that needs to be asked is where does the patient want to die? Because sometimes that tells you the extent of the management at the end of life. Because many persons that cannot express their desire for example, or dislike of machines, would just tell their family, gusto ko pagpapaba ako dun na lang sa bahay. Yun ang salita ng matatata, pagpapaba ako. Naalala ko kasi yan ang lola ko, sabi, pagpapaba ako, ibig na sabihin kung mamamatay na siya, gusto na sa bahay na lang. And that made it easier for us to decide not anymore to bring her to the hospital, even when she already had signs of pneumonia from aspiration because she had a stroke. So where do they want to die? That's a very important question. So pinakamahirap makausap in my experience, Dr. Muyot, yung kamag-anak na hindi siya nag-aaral. Diba? Diba yung sitwasyon ngayon, yung anak nasa abroad, sinisisi na siya, at di mo yung nalagaan, pinabayaan yung nanay natin, pero siya yung nasa abroad. Yun ang pinakamahirap eh. The ones who are away are the most demanding of all kinds of treatment. Kaya mo bayaran na gawin mo lahat. And that will include, by the way, tests. Let's remember that sometimes, hindi lang yung ventilator at dialysis, yung mga tests na i-order nyo, hindi na kailangan siguro, no? Depende sa goal of care. So my final words are the following. As medical students, as residents, I myself, we have to continue to learn the scientific evidence. That's where we make good decisions, and that's when we can communicate whether a treatment or offer test, for example, is beneficial to the goal of the patient's care. So, huling kwento na lang, yung aming pasyente ni Mark na sa home for the aged, matagal na siya, hindi pa siya comatose, pero hindi na siya nakakagalaw dahil multiple cerebrovascular problems, no? Sabi nung kanyang kapatid, bigay po namin itong gamot na ito kasi sabi sa akin yung isang nagbebenta ng ganyan gamot, kung binigay daw niya itong actually it was a herb, it was a herb. Wala, nagising daw. So, pinipili na talaga kami, pinipili namin kasi hindi na lang daw ang katangin namin ma-offer namin yung sa kanya kapatid. Pero pag gano'n, no, if the benefit is not proven, especially scientifically, then it becomes an experiment. Remember that. And if it's an experiment, you have to demand for the proper process of doing that experiment, even if it's just one patient. So, yun lang po ang masasabi ko sa inyo. Salamat po, Dr. Muyot.
Okay, we now open the floor for questions. Any questions from the floor, from our audience?
Thank you, for your talk. Ang is my classmate. And nawala isa na Dr. Nancy Nay, Dr. Legitimize Fernandez. And you, but she took her pre-med only for 3 years. So, hindi namin siya kasama. Anyway, my question is this. I know you practice in Los Angeles. And it's in Las Vegas, okay, California. And it's anyway, I have a doctor, hindi ako geographist. Okay, geography. Now, my question is, okay, the US is multicultural. You gave us a number of principles, which I think would really be helpful in our everyday practice. My question is, do you find any cultural differences? Like if it's a Filipino family versus a Lebanese family?
So culturally, dahil to multicultural, maraming culture sa States, yes, definitely. There's a lot of differences. I find sa mga Filipino-American families, just a discussion of medical life is very hard for a lot of the family members na alam na nila na medyo malumana, pero hindi pa parang pumapasok sa isip nila talagang malaki ang chance na baka hindi sila mabuhay at mga sinusunod nito. Isa pang nahihirapan kami sometimes is yung mga Hispanic families. Traditionally, parang silang Philippines very Catholic, so there's that faith, there's that maybe, there's sort of that faith in wisdom. And when you have that discussion about the end of life, it becomes a little bit more difficult. So, not to stereotype, but these are some of the experiences. Of course, within every culture, there's also people that will look at it a little bit differently from what you expect. So, back to my earlier point about making sure that you understand when you have that discussion, just ask. And I do that. I don't understand all the cultures, so I ask them, so about that. How is it like in your culture when you run across that situation. So just to help you understand. So please individualize your discussion depending on the culture. And siguro tayo rin, iba-iba rin mga patients natin, pag-apply naman yan. Kung let's say, they come from a different area ng Philippines. Here, let's say dito sa Metro Manila.
Any other questions from our residents? From our residents?
Ising pa ba?
Yeah.
Good afternoon, sir. Kim Matanila, third year resident, sir. Little bit, I think it's a bit related. There are patients that heard their families, sir, that want to withdraw care. But you, as a physician, know it's not yet that futile. Or how do you go about, or how do you handle those cases?
So actually, I was going to ask you if you've run across the other case or the other spectrum scenario I presented. So as a physician, we sometimes feel that a treatment perhaps can be beneficial, but for various reasons, the patient and or the family may decline. If the patient is able to make that decision, remember your ethical principles of autonomy. The patient does have a right to refuse treatment, even if you decide that it might be beneficial. Case in point, I have a patient who's 80 plus years old who has severe vascular disease. Sabi ng surgeon niya, amputate na natin ang legs. Ayaw niya. So I'm basically treating him as a palliative care patient. So I was able to actually find a regimen that would control his pain so that the wife can continue to take care of him in the home. And so far, it's almost a year now that I've taken care of him. So just those little things, those little victories, the things that you do for your patients, these are the things that you look forward to. When it comes to the family, that can be a harder situation because when it's a family, who's really speaking for the patient? So again, frame it back in this way. So, kunyari kung nanay niya nakakapagpapasya ng nanay niya. Kung marinig niya to, yung recommendation, ano sa tingin mong gagawin ng nanay? Now, dito, yung adult children usually ang next decision maker. And then kung sila ang proxy decision maker, and this is something that you will still have to honor as long as it's clear cut that you explain. Kung di natin gawin to, there's a chance they're not going to do very well. Or perhaps makaingit sila tumanin. Are you willing to take that chance? So yung education and continuing this discussion is going to be very important. As I said, you're not going to win all those discussions or perhaps see your point of view. But at least it's your obligation to inform them about the treatment, the chances, the options. Cost may be an issue too. Let's say there are times like father-in-law and brother talking about dialysis and disease. Pero sabi ng tito, ayaw mag-dialysis. So na-stroke siya ngayon, nasa hospital sa ngayon, natabayaan mo. Pero malinaw pa rin na if something happens, hindi na tutuloy dialysis.
Questions from the other side? Okay.
Question ko as a patient's point of view. Kasi you mentioned, it was emphasized there, that terms of treatment preference by the doctor. Which one is to be preferred by the doctor? Prolonging life of a patient or shortening the sufferings of a patient? Gusto ko lang curious lang.
So, ibabalik ko po yung question sa inyo. Kasi po kayo ang in-charge, kayo po ang bossy, ang pasyente po ang pero kung iyakan nyo yun, kung may discussion na kayo ng ganyan, bigay nila yung option, realistic view of what will happen. Tapos, nasa pamilya. Kasi kung minsan, pag sinabi mo, gawin natin ito, so, hindi po. So, importante na talagang discuss nyo ano talaga yung gagawin nyo, bakit, sa mga salita na naintindihan. So, kung ang goal nila ay prolong ng life, gusto din ang gawin ko kasi kailangan ko namin yun. Kung gusto nyo na hindi na palliative care na lang, we have to.
Other questions from the other side of the floor? Anybody? Okay, going once, going twice. I will have the last question. Okay, sir, regarding the importance between palliative care and residence training in internal medicine, how do you meld those two situations or cases where you especially for the medicine residents? I think the training setup sometimes forces them to do anything that can be done for a patient, especially sometimes out of the fear of being audited.
So, nung estudyante pa ako, intern, madugo na yung audit na. Hanggang ngayon ba madugo pa rin? I'm not sure how to answer that because I think culturally that's one thing. But I think, it's something experiential. As internal medicine residents, getting in training, but you realize as you go into your practice, that's not how the work always works. You will have patients who will get and you will go through that experience with them. Alalahanin nila lang as you go into your practice, how can I make that difference pag malapit ko? Can I make them more comfortable? Gusto nila umuwi, nagkakapi sila as after sharing say, sila sa bahay, ano magagawa ko para na tulungan sila sa mga. Yung mga audit, wala po akong power dito. Wala po akong magagawa sa. Pero alalahanin nila po ang pasyente pa rin po yung sige sa patient. Yes, ma'am.
I'd like to wrap it up. Having been in the training, I think a lot has to do with the trainers, which is us, the consultants. And I think a lot of us are still uncomfortable with the idea or the concept of medical futility. And I think that's the message that we transmit to our residents. From a training point of view, I think this is something we should be training our students, our residents, to handle this concept, accepting it and knowing how to deal with it, precisely because this might be the most ethical way to proceed for our patients. So I think it also has, it's also because of us. That's why the residents are pushed to disregard the medical care.
So again, thank you for everyone's questions. And there are no other questions, then the session has come to a close. And we would like to thank Dr. Muyot for this very valuable Thank you for coming to this afternoon session. And again, we would like to call to help me present the law of appreciation of Dr. Muyot. Again, thank you. Dr. Fernandez, any further? Again, this is the end of this afternoon session. To everybody who logged into this session, thank you for logging in. We hope to have you in our future